Wel, pnawn da a chroeso cynnes iawn i bawb i'r cyfarfod heddiw, sef cyfarfod ychwanegol o Fwrdd Iechyd Addysgu Powys. Ac fel y gwelwch chi, dyn ni'n cynnal y cyfarfod heddiw yn fyw, a mae'n cael ei ffrydio yn fyw ar ein gwefan ni. Ac yn ôl ein harfer, mi fydd na recordiad o'r cyfarfod ar gael ar ein gwefan i bobl gael i gweld ar ôl a digwyddiad heddiw. It's a great pleasure to welcome each and every one of you today to this additional meeting of the board of Powys Teaching Health Board. As you can see, we're holding the meeting virtually. It is being live streamed via the Health Board's website, and as always, a recording of our meeting will be available to view online after today's event. Cael cwpr y dwi, sef cadeirydd y bwrdd, ac cynhelir y cyfarfod heddiw i ystyried barn y bwrdd iechyd ar un mater. Felly, mewn gwirionedd, dim ond un eitem sydd ar ein hagenda heddiw, sef y newidiadau dros dro arfaethedig i wasanaethau. Ac fel newidiadau dros dro arfaethedig, mae'r newidiadau wedi bod yn destun cyfnod ymgysylltu gafodd yn dilyn adolygiad canol tymor gyda llais i ymestyn i'r 8 Fedi 2024. Our meeting today is convened to consider our view on a single issue, and therefore it is in essence a one-item agenda. And that item is the proposed temporary service changes. We're all very aware that there's been a lot of public interest in the matters under consideration today, and as we go through our meeting, the feedback and all of that will be acknowledged and referenced in the business of our meeting, particularly as we discuss the engagement report. Now, as temporary changes, the changes have been subject to a period of engagement, which, following a mid-term review with llais, was extended to the 8th of September 2024. The agenda pack for today is available online, and it outlines the proposals and provides a very detailed engagement report together with detailed decision cases and impact assessments for the proposed temporary changes. And as we go through the meeting, colleagues will share a presentation and take us through the report, through the proposals and the engagement report prior to our taking a decision at the end of this meeting. Ac wrth i ni fynd trwy cyfarfod heddiw, fe welwch chi ar eich sgrin enwau y cydweithwyr fydd yn bresennol a fydd yn cyfrannu at ein cyfarfod heddiw, cydweithwyr gweithredol yn ogystal â chydweithwyr annibynnol. Hefyd, fe welwch chi ar y sgrin enwau cydweithwyr sydd yn methu bod gyda ni heddiw ac o ganlyniad sydd wedi cyfleu eu ymddiheuriadau am absenoldeb. On your screen, you will soon see the names of all board members that are present today and who will contribute to our meeting. And you will also see those colleagues who, for good reasons, can't be with us today and have conveyed their apologies for absence. In line with NHS Wales regulations, we are holding this meeting in public, but it's important, I think, to make a distinction between holding the meeting in public and it not being a public meeting. And so the only participants in the meeting today will be board members and those associated with the board. We always have an item, a standing item on our agendas that invites questions from the public, and we will get to that item soon. But all the information regarding how to engage with us as a board in terms of our public meetings and otherwise is available on our website. And so please do look at that, and that will explain our mechanisms for engagement. I'm pleased today to welcome two new colleagues to our board. Our new Executive Director of Planning, Performance and Commissioning, Nicola Johnson, and our new Executive Director of Primary Care, Community Care and Mental Health, Elaine Lawton. Wonderful to have you with us today. We really look forward to your contribution to our board business, and we're very much looking forward to working with you. But croeso cynnes a gobeithio fyddwch chi mwynhau eich gwaith efo ni ym Powys. And so we move now to the substance of our agenda. Please consider everyone welcomed. We've acknowledged the apologies, and we turn to declarations of interest. Of course, when changes happen to public services, and all of us who live and work in Powys, it affects us all in some way, shape or form, and therefore we do have publicly available a register of interests, and that is there for people to look at, and all of our declarations of interest are registered there. But in addition to that, does anyone today want to declare an additional interest in relation to the item on our agenda? No? I can't see. Oh, I'm sorry. Chris, you'd like to come in? Please do.
Yes, thank you, Chair. Councillor Chris Walsh. I am an independent member for the local authority. I represent the Brecon East Ward, so there are some changes that potentially impact on the Brecon community. So I just wanted to be transparent with that and declare that. I've done that in previous meetings, so wanted to do the same today.
Thank you, Chris. That's really helpful, and probably it's also helpful just to explain that clearly your role here is not as a county councillor, but as a member of the health board here to take part in this business for the interests of the health board. But clearly your other responsibilities, it's good to have those declared. Thank you. If there are no other declarations of interest, then we come to item 1.3 on our agenda, which are questions to the board. Now, as I say, this is a standing item on our agenda, and we usually ask for any questions to our board meetings to be presented no later than 48 hours before the board meeting. Now, when we reached that deadline, we hadn't actually received any questions from the public. However, yesterday afternoon, I think a set of 14 questions were presented to us on behalf of the community in and around Llanidloes. And therefore, in the spirit of good engagement and good co-production, I'm really very happy to receive those questions in the context of this meeting. I have managed and I have had opportunity to look at the questions, and I'm confident that as we go through the business of this meeting, in the content of our papers, in the presentations that we will receive, and in the discussions that ensue from those presentations, we will respond to most, if not all, of the 14 questions that were presented. In addition, after this meeting, we will provide written responses to those who have submitted the questions directly. And so I'm sure that that will deal with those questions very effectively. and thank you for them. And so we turn now to the substantial and substantive item on our agenda, item 2.1, the proposals in connection with temporary service changes. And I'm going to ask our Chief Executive, Hayley, to begin presenting this information to us. Thank you, Hayley.
Diolch, Carl. Thank you very much. I know there are a set of slides now being shared in the background. So just wanted to take the board through this presentation. It's about drawing out from the full set of papers we've prepared for today to inform our discussion and decisions regarding proposed temporary changes. So we're going to be covering generally the key points around background and context, engagement with public and external stakeholders, which references predominantly Appendix 1. We'll also be reflecting on engagement with Llais, again, and the opportunity for Katie Blackburn, Regional Director for Llais, the National Citizens' Voice body, to comment a little later. Engagement with our staff and primary care will be covered in the presentation, and again that references Appendix 3 in the overview of board papers. And then we'll take the changes. Firstly, minor injury units. There is a decision case and a integrated impact assessment contained in the papers in Appendix 4 and 5. And with regard to inpatient wards, there's a decision case and 2 integrated impact assessments relating to the ready to go home unit proposals and the rehabilitation wards. So those will be taken through over the next few slides by members of the team. I do appreciate that all members will have already fully read and considered the papers, but it is very important that we pick up on the key points, but also this is our approach to picking up the additional questions that Carl mentioned earlier that we received yesterday from members of the community. So we plan to pause for discussion after the summary of the engagement is presented, then to discuss the MIUs, and then finally in patient wards we'll stop again before we go forward to consider the full recommendations for decision by the board today. So as background, Carl, you've already mentioned that during this process, which was initiated by the board on the 24th of July, we have undertaken a midterm review on the 13th of August with Llais, which provided an opportunity for us to listen and learn. And as a result, we're reporting back today after a 6-week period of engagement with the public about the proposed temporary changes to both the opening hours of MIUs in Llandudno, Drodwells and Brecon, and also changes to the inpatient ward model impacting Llanidloes, Bronllys, Newtown and Brecon. So a little bit later, my colleague will take you through the engagement report that sets out the findings from the engagement process, and also we'll be covering the detail in the decision cases. With regard to context, the Health Board faces challenges to the quality, value and sustainability of health services for the population of Powys. And all of us who live or work here will know some of the challenges of Powys, including its rurality as the most sparsely populated county in England and Wales. We know that people in Powys live longer in good health than the average for Wales and the UK average, but there are also inequalities within the county too. Powys is at the forefront of an increasingly older population, with 28% of the county's population over 65 years of age. So this means that there are more people living longer with increasing ill health, multiple conditions, and we are finding demand for health and care services continuing to grow. We also know that there are some major challenges facing the whole of the NHS across the UK, as well as here in Powys. So some of those are reflected here. Waiting times for planned care continues to be too long, and we're still recovering after the COVID pandemic of the backlog. People are also spending too long in hospital, and we do know that an extended stay in hospital can lead to deconditioning. And we know also that this means that sometimes it's more difficult for individuals to return to their previous level of independence, and also there's increased likelihood of readmission to hospital. We know some of the workforce challenges that we face in our county. We also have a health and care workforce which is ageing, and the proportion of working age people is reducing in the county. We also have a substantial reliance on expensive agency staffing to maintain our services, and therefore it's really important that we continue to address the recruitment and retention challenges as a system in Powys. Because this is broader than just for the NHS, we know these challenges not only affects health, but also our social care sector, third sector and other partners. The other context around this is we will face increased cost of living and inflationary challenges, which affect the way services are provided. And we also have significant challenges for the NHS to live within its means. So that is the broad context that we've shared during the engagement process with the public. And I'll now hand over to Adrian Osborne, who's the Deputy Director for Engagement and Communication, who will take us through the public and stakeholder engagement report key themes.
Thank you very much, Hayley. So yes, following the meeting that you mentioned of the board on 24th of July, a comprehensive programme of engagement was put in place to raise awareness of the changes and to seek feedback. And as mentioned, the engagement narrative and materials were updated to reflect those decisions made at the midpoint review. Now, the board will have had the opportunity to find out more detail about the overall engagement process. That's as well as in section 3 of the board cover paper. There's a full detail in Appendix 1 and its annexes, which also include examples of the engagement materials and channels that were used. The report sets out that engagement approach in more detail. You can see that we put in place a multi-channel approach that included the opportunity to request printed materials. These could be sent direct to your household. We had a dedicated engagement website, ongoing social media campaign, webinar events, which were also recorded and made available via our channels, and direct mail to a wide range of stakeholders to inform them of the process and how to get involved. And members of the board also accepted invitations to attend public meetings, including in Glantuman, in Llanidloes, in Brecon and in Llandrindod Wells. So as part of this process, we heard directly from nearly 800 voices through the survey responses and correspondence. That included 735 online survey responses, in addition to 32 written submissions direct to the Health Board and 17 via Llais. And in addition to this, the engagement has reached out to thousands of other interested individuals through our social media, through the online webinars, through the 4 public meetings we attended, through meetings that we attended with PAVO in their locality events, and over 1,000 unique visits to the Health Board Engagement Hub. Now, clearly, one thing that I do need to stress is that there was a very, very clear strength of public feeling that we heard during this engagement. That will be an important issue for the board to consider as part of your deliberations. And at the time of the written report, we had received information regarding the number of signatories to 2 online petitions. And in addition to over 3,000 signatories to the 2 online petitions relating to MIU services in both Brecon and Llandrindod. As you can see on screen, yesterday the Chief Exec also received in person a petition of around 2,300 signatories focused on inpatient services in Llanidloes. And for the board's awareness, the wording of this petition was to strongly object to the Health Board proposals for changes to the provision of healthcare at Llanidloes War Memorial Hospital. So that strength of feeling was heard and is reflected through the engagement document, and it truly does, I think, reflect the pride and passion that people feel for local services within this rural county. In terms of the issues that we heard in the engagement report, there were 4 main themes. The first main theme related to minor injury units. We heard praise for the service, several respondents sharing personal and family experiences of these services. We did hear concerns about the potential travel and transport impact if MIU hours are reduced. We did hear concerns that proposals may have an impact on other services such as A&E, ambulance, shop doc or primary care, and also that people feel reassured that MIU is there for the times when they may need it, but even if they don't use it now, and particularly given that A&E services are not provided in the county. We heard concerns about care and treatment overnight for people who might still attend a community hospital, even if the MIU is closed. And we did hear a lot of misunderstanding regarding the role of minor injury units and the services provided. For example, people thinking they were there for the treatment of medical emergencies or for life and limb threatening conditions. And we also heard calls for increased marketing promotion of the services, as some felt that people were not already aware of them. We definitely continue to hear that theme of civic pride in local community hospitals, and people reflected on their experiences of services that they felt were declining in their communities and towns and villages, such as banks, post offices and schools. We received a lot of questions about whether these were truly temporary or maybe permanent, and including whether this may affect the recruitment and retention of clinical staff and the maintenance of skills. Importantly, these processes allow us an opportunity to understand potential equality and well-being impacts, and we've considered and received a wide range of comments in that respect, as well as in relation to well-being of future generation goals. We did hear some support for the proposals as a prudent step to address demand within available resources. And people also put forward alternative or complementary proposals, such as alternating opening hours between the 2 sites in Llandrindod Wells and Brecon. And we did hear suggestions for mitigating potential impacts if the changes were approved, for example, through promotion and marketing of alternatives to MIU. One thing we heard frequently as well was people's concerns and anxiety that there wasn't a district general hospital within Powys and that these services are provided outside the county, and people asking about the way that NHS is funded both locally and nationally. And we did hear several comments about the engagement and decision-making process, which I will come to later. So just quickly on inpatient wards as well. Again, we heard a lot of praise for community hospital inpatient services, and people shared their stories about their own experiences and those of their loved ones, including, for instance, at end of life, receiving end of life care within their most local community hospital. And in that context, we heard their concerns about travel and transport, particularly for family and unpaid and informal carers, and if patients do not meet the criteria for admission to their most local hospital, and what that might mean in terms of impact on travel and distance in order to visit a loved one in hospital and to be with them either at the end of life or in order to support them during their recovery. We heard concerns about continuity of care, including whether patients may experience multiple hospital moves if their condition either improves or deteriorates. And we also heard concerns about the wider impact on the range of services that might be available, including, as we said, end-of-life care, whether we'd continue to allow direct GP admissions, and the opportunities to reduce or prevent acute hospital admissions through the use of local community hospitals. And again, very much strong civic pride in local community hospitals, including the way in which facilities had benefited from public subscription and fundraising, including from Leagues of Friends, and concerns that this may lead to services declining or being downgraded. A considerable theme that we heard during the engagement and through public meetings was around social care as well, and the recognition that some of the challenges faced in the NHS may be due to factors in the social care system and the lack of availability of packages of care to support people to leave hospital in a timely fashion. And again, we heard those issues about whether this would truly be temporary or permanent, scepticism about whether financial benefits would be achieved, seeking to identify potential equality impacts. We did again hear support for the proposals, suggestions around mitigating factors, and once again heard calls for us to be expanding the facilities available in Powys, including seeking opportunities to develop a district general hospital within the county. In terms of wider health and care, I've covered this briefly. As I said, we had requests for a DGH or consultant-led A&E department within Powys. We received comments about the overall funding for rural care and a range of comments about the availability of social care, including pay levels for paid carers too. And on the engagement and decision making, we had comments about whether or not a case for change had truly been demonstrated. And again, it's important for the board to note that we did receive requests to either pause or stop the engagement, or for a further period of engagement or consultation to take place. All of that detail is contained within the engagement report with you today, but happy to take questions later. But before we do that, I'd also like to invite Katie Blackburn, the Regional Director from Powys Llais, to share a few words, and the observations from Llais can be found in section 4 of the report and also in the appendices. So Katie, I'd like to invite you to speak.
Diolch yn fawr, Adrian. Thank you very much. As Adrian says, I'm Katie Blackburn. I'm the Regional Director for Llais in Powys. And I just thought it might be helpful before we start, particularly as there are some new colleagues around the table, just to sort of very briefly just share with you the role of Llais. So Llais is an independent statutory body there to make sure that the voices are not only being heard, but also listened to. And so Llais is not part of any decision-making process. And I just want to be very clear about that. So I think from our perspective, I just want to share a few thoughts and observations. We managed to have somebody in attendance at 3 of the public meetings, Glantwmin, Llandrindod and Brecon. As Adrian has referenced, we have received a number of correspondence, which we have shared with the Health Board for inclusion in their analysis. And we've also met with a number of individuals who requested a meeting. So we had a meeting with a couple of representatives from Llanidloes. So in relation to what we've heard, Adrian's gone into significant detail, which I'm not going to go into that level of detail. We've heard a very, very strong sense of community feeling, of passion, and actually a really strong sense of loss. We've heard a lot about the concerns around potential travel issues, non-emergency patient transport, the challenges that we all face with public transport in rural Wales, and with the visiting hours. And the third key area of concern has been the concern that temporary will become permanent. Hayley has referenced the midpoint review, which was held on the 13th of August. That was held with the Chief Executive of Llais nationally and myself as the Regional Director. And in that meeting, we agreed that it would be beneficial, particularly given the strength of feeling that was apparent, to extend the engagement period and to have an extraordinary board meeting today, where the discussion could be taken in the discussion and the decision could be taken in public. We believe that the attached engagement report, which and the appendices which Adrian has touched on this morning, reflect what we heard. And finally, I just want to say that should the board take the decision today to move forward with these proposed service changes, my letter of the 3rd of October states our expectations. And for the benefit of members of the public who perhaps don't have them up in front of you, I am going to read them out quickly because they are extremely important in my view. So Llais Powys' expectations are that they remain an observer with speaking rights on the Strategic Change Programme Board. That Llais has assurance of Powys Teaching Health Board's commitment to continually evaluate the temporary service changes, that a clear engagement process is put in place to hear the voices of Powys residents and to help inform options for the future, that there is a commitment to evaluation, including the option for reversibility, that the mitigation plan and activity is reviewed, evaluated, and where necessary adapted on a regular basis, and a commitment to monitor the impact across all affected areas, including identifying unintended consequences. I'd just like to say to you all that Llais remains committed to working with the Health Board going forward, regardless of the outcome today, to make sure that the views and the voices of the communities of Powys are not only heard but listened to. Thank you.
Thank you very much for those important input from Llais. And in terms of the next stage of engagement, I'd like to hand over to Deborah Wood-Lawson, our Director of Workforce and Culture, to speak about engagement with PTHB staff.
Diolch, Adrian. I'll cover staff and staff side engagement, and then we'll hand over to Kate for primary care. So our staff and their representatives are key partners in the design and delivery of future services, and we have continued to use all our well-established mechanisms to engage and inform. In addition to our existing well-developed arrangements with the trade unions, such as local partnership forum and regular monthly meetings, staff side have also had an open invitation to attend both programme board and the working groups. That's important to ensure that the staff voice is embedded throughout the programme. More information about engagement can be found within section 5 of the report and in appendix 3. If I can hand over to Kate Wright, then Executive Medical Director, to cover the next bit of the report. Diolch.
Yeah, thank you, Deb. Good afternoon, everybody. So we really recognise and value the vital role that primary care plays in serving the local communities in Powys. Their expertise and the understanding this brings really important, and the challenges being faced as well as the opportunities for improvement. We also recognise that it wasn't a smooth start to this period of engagement, which does reflect the pace at which we're needing to work to respond to the critical challenges facing the quality, value and sustainability of local health services, as well as the additional constraints of the pre-election period. The engagement programme has provided a really helpful opportunity for learning and review, and there are a number of actions we'll be taking forward to reinforce our commitment to engage with primary care. Across the engagement, key issues and themes have included a range up for step-up admissions, including prevention of unnecessary admissions to DGHs, particularly in relation to ready-to-go-home units. Arrangements for end-of-life and palliative care, particularly in relation to the ready-to-go-home units. Travel and transport, as previously discussed. Community hospital staff and retention and maintenance of skills. Availability of social care has been a theme throughout. And there has been some scepticism about the case for change. And not only the case for change, but also a sense of what other changes could come. That said, there's also been a lot of support for the proposals and understanding for the reasons behind them. The temporary versus permanent nature of the proposals and plans for developing a green long-term shape of the health services being a recurrent theme. So the Health Board Executive Team has ensured conscientious consideration of the key issues raised by primary care, and they have contributed to the updated decision cases, impact assessments and mitigations. No viable or feasible options have been identified that enable the Health Board to respond to the immediately pressing challenges to the quality and value, but feedback through the engagement process and on an ongoing basis will continue to inform the development and agreement of the future permanent state of safe and sustainable health services in the county. Thanks, and I'll hand back to Carl now, I think.
Thank you, Kate, and indeed Hayley, Adrian, Deb, and everyone for presenting what is a huge body of information. Of course, we do have the detail of that in the papers that were circulated a week or so ago, but the slides and the presentations are really helpful in drawing out the salient and important points. So thank you very much for that. I'm going to open it to questions, discussion, conversation now. I'm conscious that Katie referenced the expectations from Llais. Hayley, I don't know whether at some point you or a colleague may like to just comment on those expectations and you know, from an executive perspective, the response to those expectations. But I'll kind of, you know, leave it for you or somebody to come in as part of the discussion. But Kirsty, would you like to comment, please?
Thank you very much, Chair. I have a few questions I'd like to ask on this section of our discussion. Firstly, relating to public engagement and to seek assurance that we are confident that the extended period has provided everybody in the county who would wish to give their views to the Health Board have had an opportunity to do so during this period, and to seek assurance that the process that we have been engaged in is one that sits comfortably within the regulations and the rules as stated by the Welsh Government. Secondly, on the issue of engagement with primary care, I think it's fair to say that at best our primary care colleagues have been disappointed, certainly from the beginning of this process, of a lack of engagement, and at worst have been very angry about the lack of engagement prior to the announcements. And I'm very aware of the constraints that colleagues are working under at that time. But in the paper, it does say that in moving forward, we will strengthen our partnership arrangements with our colleagues in primary care to avoid the situation in the future. And I'd be grateful to understand what that looks like. And a consistent theme in the engagement has been around the issues of social care, which of course do not directly fall under the statutory responsibilities of Powys Teaching Health Board. I know that Nina from Powys County Council is an observer on our board and is here with us today, but I wonder what steps the Health Board will be taking to use the information and the feedback from this process to support our colleagues in Powys County Council as they continue to grapple with the very real challenges that they face in providing social care for the population of Powys. Thank you.
Thank you, Kirsty. Three questions there. Everyone being involved, primary care engagement and social care partnership. So I'm just looking as to who would like to respond to the points that Kirsty makes.
Al, would you like me to come in first?
Yes, please do, Hayley. Thank you.
Yeah, okay. And other colleagues may want to add just on the point around the period of time that we've covered, and do we think everyone's had the opportunity to respond? You know, I think it's demonstrating for me that we've directly heard from nearly 800 voices through the survey responses and correspondence. So 735 online survey responses, in addition to 32 written submissions direct to the Health Board and 17 via Llais. And in addition to that, we had reached out through some webinars and also took up the invitations to attend several public meetings where a large number of people, difficult to give a full head count, but we think it's well over 500 people attended those public meetings. And clearly, we've just referenced a petition that we received yesterday, as well as we know there are others in development. We just haven't formally received that at this this point. So I believe that we put in place a comprehensive means of engaging with the public during this 6-week period, and that is demonstrated by the level of response and the volume of response that we've had. With regard to meeting service change requirements, we were going to cover that a little bit later on in the presentation, but my view on this is that, and you will see through the correspondence and the midterm review with Llais, that in our opinion, through the assessment, that it does meet the service change guidance forward, but happy to cover that in a little bit more detail later in the presentation. And with regard to primary care engagement, it would be fair to say that we have, at that early stage, I have personally apologised to particularly some colleagues, because we were at a difficult time of the pre-election period when we were looking at those initial changes. But there has been an offer and numerous meetings that have taken place with our primary care colleagues over the last few weeks, and continue to do so to strengthen it moving forward. But it may be that Kate Wright may wish to comment specifically around primary care engagement. And obviously you've drawn the huge response from the public around social care. We work closely with our social care colleagues, not only through the partnership arrangements that we have, working with the wider system through things like the Regional Partnership Board with our third sector colleagues, but we also have a joint leadership team with the local authority. And we've always shared engagement insights with each other and look at how we can respond to the challenges in partnership. And we have shared that information, and will continue to work in partnership to try and address all of the challenges we face. So that is continuous focus for us, but we have shared that information openly, but not to pass the problem on, to work in partnership and see if we can do things differently together.
Thank you very much, Hayley. Kate, do you want to comment further on the primary care engagement?
Yeah, please, Carl, briefly. So yeah, just to really repeat, because it's important that the pre-election period left us in a difficult position, and I too have apologised, as has Hayley, because it wasn't a position we wanted to be in, and it was very difficult. And I understand that our colleagues would have been really disappointed and upset by that. That said, then we have had several meetings. I'm meeting practices and continue to meet the practice, and that has been a really helpful and constructive conversation. We've been able to talk through plans in more detail, to be able to really carefully consider what we've heard, and it has helped us plan, helped us think about mitigations, and help us develop standard operating procedures, etc. So that's been really valuable, and that will, as Hayley says, continue. We've held tabletop exercise with multidisciplinary team, but several of our primary care colleagues there, which has been really helpful in testing some of the scenarios. And again, that is, we know that we have a lot of work to do, and we are absolutely, in terms of your question about how that looks going forwards, then we have previously in our work and with our cluster working and in workshops will be involving all of the multidisciplinary team, including primary care, because they are going to be absolutely vital in helping us with their expertise and move the plans forward. So there are plans in place, and there'll be more plans coming, because we recognise how really, really important or vital that is.
Thank you very much, Kate. Simon and Jen would like to comment. So I'll take Simon and then Jen, and then we probably need to finish this bit of our discussion so that we can go on to consider the next aspect of our meeting today. But Simon, please come in.
Thank you, Chair. Simon Wright, independent member. I've got 3 questions. Lots of the feedback indicated, I think it was described as scepticism around temporary change. And it struck me that there could be various interpretations of the word temporary, and it'd be helpful for clarification for all of us, in particular, I think, those who are watching our meeting, if we could just have clarity on the meaning of temporary in this context. Does it mean something which is going to be taken away and returned to what we have now? Is it something that allows us to test things evaluate, and then to take a decision, or as some people believe is the decision already made. So I think it'd be helpful to understand definition of temporary in this context. Second question relates to primary care. Completely understand and endorse some of the comments made, and glad that exec members have engaged with primary care, and apologised for the start of the process not being perhaps as we would have wished. But can I ask whether primary care have put forward any alternative solutions or proposals to the ones that we've put forward, other than their assessment of the temporary changes that have been put forward? Have there been any other proposals? My last observation is this is an incredibly comprehensive set of engagement activities, providing a really detailed reports for us today as a board to consider. And it's clearly required a phenomenal amount of work from the executive team of the Health Board and many others. And I know this is for 2 temporary changes. And I recognise absolutely the engagement is incredibly important, and there are lessons to be learned about how we've conducted that, certainly, and earlier engagement with primary care being one of those. I guess my question is, are we content that the level of engagement and the work that's required from our colleagues is proportionate to the change decisions that we are being asked to make here, given we also know we are in a context of very significant challenge for the NHS, where changes such as these are likely to be required again, and quite possibly more significant changes in the future. So I'd just like to know whether we think this is a proportionate approach. Thank you.
Thank you, Simon. We will go to Jen. We won't lose your questions, Simon, but just before we go to Jen, I'm aware in this section of our meeting, we've also had presentation and papers and information about staff engagement, and perhaps in a couple of minutes, I might go to Cathy Poynton, who is our independent member colleague from a staff side perspective. So Cathy, I will come to you in a couple of minutes. You may want to just give a perspective, but let's go to Jen.
Diolch yn fawr, Carl, Cadeirydd. Jennifer Owen Adams, independent member. Mine's quite a specific question, actually, which was I'd like to better understand the issue of continuity of care. This is identified, Adrian, you were saying that this is identified in the summary of the consultation findings in relation to the inpatient ward model, those proposals. I'd like to better understand what the cause for concern is in relation to continuity of care. What was it that the public were telling us which gave them cause for concern in relation to that matter? Thank you.
Thank you, Jen. So just to summarise, we have questions from independent members about what does temporary mean, any proposals from primary care, the proportionality of engagement, and what were the concerns in relation to the continuity of care. So again, I will just look as to which colleagues would like to come in and respond to those questions. Adrian, please.
Thank you very much, Chair. Yes, in relation to Jen's final question there about continuity of care, I think some of the issues that we very much heard there was people were seeking to understand what this new model of inpatient care would mean. And as an example, if one hospital was designated as ready to go home and my loved one was admitted to that particular hospital, what would happen if their condition deteriorated? Might they then go to a different hospital for a higher acuity of care? And then actually, once they were reassessed as ready to go home, might they come back? So they felt there was a concern that we very definitely heard, that people were worried that this might lead to multiple moves between hospitals within the county, and looking for a level of assurance about how we would set criteria around clinically led admissions and around how we manage step up and step down. And I know that Claire Roach, our Executive Director of Nursing, will want to cover those issues in her presentation later in more detail.
Kate, would you like to just add a comment in relation to alternative suggestions from primary care?
Yeah, thank you. And thanks, a good question, Simon. So I think the answer is, were any significant workable alternative suggested, then no, we had very few actually. What we have had though is just constructive discussion and suggestions about things that we might want to think about in if we were to develop the temporary changes. But in terms of alternative suggestions, I've not had any significant ones, no.
Thank you. And might I invite our new Executive Director of Planning, Performance and Commissioning, Nicola. I just wondered, Nicola, I know you are very, very new to the board and so on, but whether you had, particularly on the proportionality matter.
Diolch, Cadeirydd. Yes, members will be aware that we're not the only health board that is engaging on service changes, some very similar to our own, notwithstanding the differences in our population, which we all recognise. And we will be, in terms of the lessons learned, which we've all talked about, we will also be considering in that the approaches taken across Wales, as well as our own, to consider that question of proportionality, which Simon has raised. Thank you, Chair.
Thank you. And Hayley, the final matter that was raised was the what do we really mean by temporary? Might you want to just offer a view?
Yeah, so we've clearly set the timeline of 6 months in the context of this temporary change. And the reason we've done that is twofold. The first one is this is testing new ways of working, and we've got a very clear evaluation framework in the papers, which we will be bringing back at appropriate junctures for the board to see how these changes are being implemented, and also, most importantly, what outcomes and impact the changes are having for our population. The issue around the alternative suggestions, what I would say is that, and we've got this a little bit later as well, there needs a broader conversation about, not about these temporary changes, but the learning from these temporary changes, and that point that Nicola raised around how does a process around engagement, etc., fit within that All Wales context is something we can review over the next few weeks and months, but also moving forward to how we involve primary care and all partners and the public in the dialogue about the future long-term model. So although in relation to these specific temporary changes there are no alternatives, there's been requests to stay as is in terms of not changing the model, I do feel that there have been early signs both within the public conversations with our partners and with primary care and our staff of suggestions about how we can move forward for the longer term, and I'd be keen to bring those into the discussion when we're looking at the options for the future for the longer term. Thanks, Carl.
Thank you all very much indeed. So we're going to move on now and to look more specifically at the proposals in relation to the minor injury unit changes. And Kate, I think we're coming back to you. Thank you.
Yeah, thank you, Carl. Okay. So firstly, I'd just like to remind the board of the challenges that led us to consider the temporary changes earlier in the summer to the MIU services, sorry. So on average, our minor injury units in Brecon and Llandudrod see just 1 or 2 people per night. It's not good use of public resources or of the specialist skills of the nurse practitioners who provide the services. It's difficult to recruit and retain sufficient emergency nurse practitioners to run the current opening hours. And this has resulted as it's leading to close the MIUs at short notice, and that's a growing problem. Between January and September 2024, Llandud had to reduce the hours 57 times and Brecon was closed overnight 28 times. And that means that we've just not been able to provide a reliable service. Nearly all of the patients who attend overnight could or should attend during the daytime. So we identified opportunities for temporary changes so that the service would be safer and more reliable. By offering more reliable opening times and reducing the number of unplanned closures, it would mean there was no lone working out of hours, which would be safer for staff and patients. Patients would continue to be asked to phone first, as we do now, to allow assessment of the needs over the phone, so that some patients can have advice provided on first aid. They can be given slots to come at appropriate and at a convenient time, and they could be redirected to other services if MIU is not appropriate for them. There's also greater opportunity to cross over the cover between the NIUs, which gives a better opportunity to improve our training as well of our staff. As aside to the work, we also plan to make some changes to the overall staffing model, which better will meet the needs and demand of the service. So this slide sets out the proposed changes to hours. I'll stress that Brecon and Llandudno have already experienced frequent reductions in these hours due to the challenge in securing appropriately trained staff overnight. For example, this week, Brecon had closed overnight twice, and Llandudno is closed early on 2 evenings. So this is really a significant and ongoing problem. Can you move on to the next slide, please? There we are. So this slide is a reminder of what service NMIU does and doesn't provide. It also provides a strong visual representation of the patterns of attendance we see in our MOUs. And as you can see from the graph there, the attendance overnight is very, very low, with Llandudno seeing just 0.8 of a patient in a shift and Brecon 1.4. And just to stress, that is per shift and not per hour. So looking at Adrian's comments earlier, we need to bear in mind the engagement has really showed there's a very strong and clear strength of feeling that we've heard. As well as hearing calls to pause the proposals, we've also heard people's anxiety about accessing urgent and emergency care. We heard suggestions that we should increase rather than reduce the MIU hours, or even establish a district general hospital in Powys. And we've explained during the engagement process why that's just not possible. We've also heard a lot of misperception and misunderstanding about the role of an MIU, and these do appear to have formed the basis of some of the concerns that we've heard. We've also heard anxiety about how people would access minor injuries care overnight if the unit was closed. It's important to stress that the significant majority of the minor injuries can wait until the MIU is open the next day. Indeed, currently, patients often need to come back the following morning as we don't have x-rays available overnight. And as now, if somebody were to need help overnight, they can access existing services such as 111 or A&E if their conditions are serious. Importantly, we haven't identified any significant problems with care relating to MIUs that don't currently open overnight, and that has been monitored consistently. These proposals would help us to offer a reliable service and reduce the risk that somebody attends an MIU when it's unexpectedly closed, which could be really, really unsafe. We've got well-established clinical protocols for managing people who do arrive at community hospital to find the units closed, and they will continue. They've been reviewed and will continue. Really important to, I think there was a perception that ShropDoc might not continue, and it's important to reinforce that ShropDoc won't change. They will continue, as they do now, to provide access for GP services overnight when general practice is closed, for example, if a child is unwell. The engagement process hasn't identified any feasible alternatives that enable us to respond to immediate challenges that we face. We can give assurance that these are temporary changes and that they could be reversed if there was any suggestion that should happen by evaluation or review. And if a trigger to reverse is identified, then the service would resume as soon as we'd had chance to reinstate the rotas. In terms of monitoring and evaluation, then we already have monitoring in place for the units, and especially for when current units are closed overnight, and they will continue. But the engagement has allowed us to examine and to develop other mechanisms and other systems for evaluation, and key to that will be looking to see what should happen if people are trying to get help overnight. So following careful and conscientious consideration of the issues raised, we continue to commend that the proposal for the temporary changes subject to the evaluation and monitoring framework being in place and continued work on mitigation, including a clear publicity campaign to raise awareness of the periods of closure, reinforcement of the opportunity to phone first before attending MIU, and strengthening of messaging around where people should attend with given conditions. Just one final factor that I need to draw attention of the board to is some imminent work to upgrade some of our X-ray equipment. The first phase of the work is due to start in November, and this means that X-rays will be out of action at Welshpool, Landard and Ustra Gunlight for a number of weeks while the current equipment is removed and new machines are installed. So we'll need to align our publicity for any change in MIU operating hours with the publicity for our X-ray replacement programme. Thank you, Carl. I'll hand back to you now.
Thank you. And apologies, colleagues, for slightly interrupting the very smooth smooth progression of this discussion, but I omitted earlier to ask Cathy for a staff perspective, and that, of course, that relates to the MIU proposal as much as the inpatient wards proposal. And I know that we've got some colleagues that want to come in on the MIU discussion, but I will firstly go back to Cathy. Cathy, would you like to share any thoughts?
Good afternoon, Carl. Yeah, throughout this process, we had a bit of a glitch at the beginning with communications with the staff, which wasn't very good, I've got to admit. So we worked through those problems. Quite timely, you brought me in through after the MIU presentation, as all the staff have been asking for a change in hours for quite a while. It's not a recent thing, so they welcome the changes. We've had one or two issues which we're working through and have worked through. We've ended up with extra training and protected learning time for the staff. If we go through with the closure of the hours, it will help them tremendously. And in both areas, if we go ahead, we've introduced rotational staffing, which again will help the staff. And in co-locations, we've had one or two dissenters, but all in all, the staff have been asking for these changes. And not just for a couple of weeks, we're talking months and months and months. So it's a good thing from our point of view.
Thank you, Cathy. Thank you very much. And so we'll go now to Robert.
Thank you, Robert Lewis, independent member. My question is about the unplanned closures of MIUs. I'm really looking for some confidence that the service will become significantly more reliable after the adoption of these changes. For example, I don't know to what extent MIU staff could be transferred between the different centres, and while the precise benefit of reduced opening times on the reliability of service would become clear over the 6 months of the proposal, if accepted, has the board modelled the impact of these proposals on closures? Put another way, if we had applied these new times last year, would the effect be marginal or significant? There were 85 closures in MIUs between January and September, between Llandod and Brecon. Do you have any sense of how this number would be reduced, other things being equal? Thank you, Chair.
Thank you. Let's go next to Chris.
Thank you, Chair. Thank you, Chair. Yes, just to pick up on a couple of issues here. Obviously, it's a concern to me when the unit has to close in any shape or form, because that's taking services away. One of the questions that has come in for me is in relation to the relationship that the minor injuries has with Shop Doc, and is there any consideration of it trying to work through that relationship so that it can improve that modular care going forward? The other issue that comes to me is that based on the changes that are proposed, the 8 to 8 service that's planned for Brecon, is there sufficient staffing within the system to then avoid those closures? And have we then considered any of the options around extending up to midnight? Because that has been raised as well on there. And are any of those other models going to be considered during this evaluation process? Because it's about setting the services up fit for the future moving forward. And I'll stop at that point, Chair. Thank you.
Thank you, Chris. And I'm going to bring in Steve Elliott now, and then we'll go to Kate and other colleagues if needed to respond. But please come in, Steve.
Thanks, Steve Elliott, independent member. I'm just looking for assurance that the proposed changes won't have a detrimental impact on the waiting times for MIUs. We're currently achieving the 4-hour waiting time target for our MIUs, and I just want to seek assurance that these changes won't have an impact on that. Thank you.
Thank you very much. So again, just to summarise, so questions and seeking assurance around, will this increase the reliability of the MIU service? And I suppose that links as well with Chris's point about sufficient staffing, not forgetting Robert's point as has the impact been modelled? Relationship between MIUs and Shropdock, will it improve that or impact upon it? Have other alternatives been considered, such as opening till midnight? And will there or will there not be a detrimental impact on the current good performance of MIUs? Shall we go to you, Kate?
Thank you, Carl. Yes. Okay, so taking them in order. In terms of whether we've modelled the absolute number of reduction in closures, and no, I don't think we have done that, but what we know is that the closures, the difficulty has been staffing out of hours and overnight, and that's when we're tending to have to find agency staff. So I think what I can say is that we are confident that that number will significantly reduce, and I would like to see it go to 0. But I'm very confident we'll be a very significant reduction, but honestly, we haven't modelled it. In terms of the relationship with Shropdock, then we have a close working relationship. They will occasionally, for example, help if there is, if the nurse practitioners have a question, they will come and help, and that would continue. In terms of whether we have whether we have modelled in terms of the 4-hour target, then what we have done is done some benchmarking and looking at our numbers of attendances, benchmarking against activity in other health boards and looking at the staffing model in general. And we are confident that even if we were to see an increase in attendances in our units, then we would still easily be able to meet the 4-hour target. And I think that the question about the opening until midnight, I think comes down to efficiency. We know that the numbers of people attending after 8 o'clock are very, very small indeed. And then in fact, some of those people are rescheduled follow-up patients. So the number of true first attenders with an MIU are very, very small. So it's very difficult to justify in terms of efficiency grounds, having the units open after 8 o'clock, given the graph that we saw. Also not satisfying for staff. It's a very, very low volume of people to be seeing during that time period. We know that by definition, and from our own audits, that the people that attend with minor injuries can be very safely seen the next day. And for that reason, that is really the reason for recommending the changes. And so no, that we would be very hard to justify keeping the units open till midnight, because the volume of patients are just not there. I think that's answered the questions, but if not, I can fill in the gaps.
Thank you, Kate. And I'll just fill in a little time. Should any colleagues want to come back who feel that they haven't received the assurance that they were seeking? No? So Thank you very much, Kate. And so we go from the discussion on the proposed changes to minor injury units to receiving a presentation now linked with the information we have as regards the proposed changes in our inpatient wards. And Claire Roche is going to lead on this bit of the presentation. Thank you, Claire.
Diolch, thank you, Chair. Good afternoon, everybody. Again, like Kate, I would firstly like to remind the board of the challenges we have previously discussed. And these are quality challenges, and the board will note in our presentation the infographic around the quality standards of safe, timely, effective, equitable, efficient and person-centred care. Patients are spending longer in community hospitals than they should. And one reason is because they are waiting for packages of care in the community to support them to go home, regardless of where home may be, and including a care home. If people spend too long in a hospital bed, it can lead to deconditioning. And what this means is people losing their muscle strength, their ability to care for themselves, and also become confused or disorientated. This can make it much harder for people to return home, and it can increase the likelihood of readmission to hospital. We absolutely need to break this cycle, and we need to support people to go home as quickly as possible. There are challenges in relation to staffing. The rural nature of Powys means that our specialist skills are spread thinly across the county. Skilled staff are spending a lot of time travelling between different hospitals. Regarding the standards of both safety and efficiency, we absolutely must take steps to reduce agency spend. In common with other services, we face challenges in both recruiting and retaining skilled staff. We have a high dependency on agency staff, which is extremely expensive for the public purse. The proposals would reduce our reliance on agency and temporary staff, who, in addition to being more expensive, are often unfamiliar with the wards and the patients, potentially leading to reduced quality of care. We have identified opportunities for temporary changes so that the service offers better quality and value and is person-centred. Specifically, these are designated sites as ready-to-go home units and designated sites for patients requiring rehabilitation, building upon our existing arrangements for stroke rehabilitation. This means that more patients will be in an environment, better focused on their care needs. The next slide outlines these proposals. There will be changes to 4 wards. 2 wards, Graham Davis Ward at Llanidloes and Llewellyn Ward at Bronfleece, will focus on patients who are ready to go home. 2 wards, Epynt Ward at Brecon and Brynhilog Ward at Newton, will focus on specialist rehabilitation. Our remaining community hospital wards will remain unchanged. In this slide, I'm going to talk about learning and review for the ready-to-go home units, and then I'll pass on to my colleague Claire Madsen to talk about the rehabilitation units. The ready-to-go units will provide care for people who are ready to go home. They will be person-centred. They will have a strong focus on enabling people to maintain their mobility and promote independence, reducing the risk of harm from deconditioning. The philosophy of these units will be to get up, get dressed and keep moving, and family and friends will be actively encouraged to work in partnership with the nursing team to support their loved ones to achieve this aim. Both units will continue to provide end-of-life care, and our evaluation during this period of temporary change will focus on patient and staff experience. including any impact on recruitment and retention, and a reduction in agency staff will also be key to this, enabling continuity of care for our patients and substantive members of our team, supportive, effective team working. I do note, Carl, that there was a conversation around continuity of care earlier, and I'll therefore pick that up when we have our discussion. I'd like to now hand over to Claire Madsen, Executive Director of Therapies and Health Sciences.
Thank you, Claire. So it's worth noting that the proposals for rehabilitation were not a major theme in the feedback we heard. However, it is important for us as a board to reflect on what we have learned and what we've heard. So I just wanted to pick out a few key points around the rehabilitation units. So it's worth noting that the new rehabilitation model actually builds on the success of our current stroke units, and it further enhances our rehabilitation offer. So this is an improvement in our current offer to patients in Powys. And this model allows us to focus on the work of our multidisciplinary teams and ensure we can deliver evidence-based rehab and meet the standards required for good rehabilitation. And this enhanced model will also allow us to bring back patients to Powys earlier to receive their rehabilitation closer to home, those patients who might have stayed in the district general hospitals a little bit longer before we were able to offer a bespoke rehabilitation offer. We did receive questions to the board, as Carl mentioned earlier, and one of the questions was whether or not our MSK physiotherapy service would be unchanged at Llynedloes Hospital. And I'd just like to confirm that we have no intention of changing anything with our outpatient physiotherapy service. And also our physiotherapy and occupational therapy community services will remain exactly the same in those areas. And we will also be offering a rehabilitation work in reaching into the ready to go home units, who will support people who need any extra care on those units. So just a reassurance there, really. The engagement hasn't identified any feasible alternatives, as was asked earlier. And I just wanted to give assurance that we're not actually reducing the numbers of any beds in any of our locations. We will still continue to see the same number of patients across the whole of our bed areas. So I just wanted to say that the engagement has really helped us identify areas to work on and has informed the evaluation measures that we will put in place to ensure that we robustly evaluate the model. And of course, at the end of the 6 months, we will be looking at the next steps based on our evaluation. So following careful and conscientious consideration of the issues raised, we continue to recommend the proposals for temporary change subject to the evaluation and monitoring frameworks we have put in place. So I'd just like to hand back to Carl now. Thank you.
Thank you. And perhaps Claire Roche, we might just, you mentioned that you might want to just add some comments in relation to continuity of care. Would you like to do that now, please?
Yes, thank you, Chair. So I think specifically in the presentation, we were highlighting that the reduction in reliance on temporary staffing, in particular agency staffing, really does have a positive impact in terms of having less temporary staffing being utilised within the ready-to-go home units. And therefore, that should have an impact on continuity of care for the people in those units, because, of course, they will be cared for by the substantive team of staff. I also think it is important that we recognise that actually, there are occasions when our patients do need to move from one setting to another, depending on their care needs, whether that is a move to a district general hospital or occasionally even moves in between our community hospital sites, depending on the environment of care. So, for example, not all of our hospital wards may have piped oxygen. They may only have cylinders for oxygen, and that affects the degree of flow of oxygen that patients will require. So I think where our focus will always be on trying to provide the best continuity of care for our patients, to minimise the number of unnecessary moves for our patients. But equally balancing that with ensuring that people are having the right care in the right place. Thank you, Carl.
Thank you very much. I can see that Steve Elliott wants to come in, so please do, Steve.
Thank you, Carl. Probably a question for Claire regarding the staffing on the ready-to-go home units. I'm just wondering what actions you're taking to mitigate the potential loss of skills by staffing, particularly registered nursing staffing on those units. I note that there's no intention to reduce the number of registered nursing establishment on those units, but potentially a reduction in healthcare support worker establishments, which seems slightly contrary to to what would be expected given the expected care nature of the people on those units. So perhaps if you could respond to that. Many thanks.
Thank you, Steve. Kirsty, please.
Thank you very much, Carl. We heard during the engagement section concerns raised in primary care around the impact that the ward changes will have on GPs' admission rights, and I'm just wondering if we could clarify the relationship that GPs will have to admit to our wards. And obviously, some of our GP colleagues provide a service to us. Some of those services may need to change. Could you explain whether these changes will have an impact on the sustainability of any of our GP practices as a result of these changes?
Thank you, and we'll go to Simon. To Kathy.
Sorry. Mine isn't in the form of a question. It was just to inform that when we were in discussions with staff concerning the changes for co-location and for the rehabilitation sites, that it was brought up and the staff were enthusiastic and wanted to bring in different job roles, so a blended job role, and they felt that they would get more out of their job and what they were doing if they could expand their knowledge and everything else that went with it. And the fact that we would introduce a rotational staffing model. Just to let you know that. Sorry.
No, please don't apologise, Kathy. That's a very helpful comment. We will invite Kate and others to come in. I'm just thinking, Paul Buss, our Director of Clinical Strategy. I don't know, Paul. I will come to you if you would like to add anything to this particular part of the discussion. But let me go initially to Simon.
Thank you, Chair. Simon Wright, independent member. I was just reflecting on some of the points raised in the engagement report, page 41 of 65, that talks about some of the mitigations that have been suggested. So I'm just interested to hear how we as a board can be kept appraised of considering and taking forward some of those mitigations that have been put forward around flexible visiting hours, and also around supporting people with respect to transport, which is one of course, the key issues that were raised during the engagement activities. Thank you. Okay,
let's pause there, but we do have another couple of colleagues that would like to contribute to this part of the discussion. But there's the issues, notwithstanding Kathy's helpful contribution in relation to retention of staff in ready-to-go home units, GP admission rights, and any impact on the sustainability of GP practices, and the suggested mitigation actions, and are we intending to follow any of those up? I'll go initially to Kate. Thank you.
Thank you. So on the GP admissions, then GPs will still be able to admit patients for step-up care. I think we have one of the things that we heard strongly, and I think rightly, during the engagement process was about the end-of-life care. And there's been really careful modelling of that. We held a tabletop exercise when we ran through scenario very carefully. and we're reassured that actually the model for end-of-life patients would look very different. It was hard to think of many scenarios when they couldn't continue to be admitted as they are now. In fact, the only scenario that really was raised was that of a site not being able to provide sufficient oxygen, and they may then need to be looked after somewhere else. That is a current issue, so that would not be new. So GPs would still be able to look after the majority of the end-of-life patients they do now. In fact, we are hoping that having strengthened the SOP, we may be able to look after more patients on the wards. In terms of other step-up patients, then as they are ready-to-go units, those units will not be able to admit step-up patients, but patients will be able to be admitted to the nearest community hospital. And that's one of the reasons in the modelling and choosing sort of areas or clusters of hospitals, that was why we did that. So they will be able to admit it, but it might not always be to the very most local hospital. In terms of sustainability, then there's absolutely no intent to destabilise primary care or reduce its income. Quite the opposite. And whilst there may be a change in the need for the way some of the services are delivered, then we've also know there are lots of opportunities. So we've already discussed with our colleagues that actually, frankly, some of the ways we deliver care could be delivered better. We know that it's really harmful to admit patients to hospital unnecessarily. So there are opportunities to strengthen the virtual ward working. There are opportunities to introduce more ambulatory type care for off-rail patients. And that would involve very similar skill sets to the skill sets being used now, if not enhanced. And there are opportunities really to expand and improve, and probably improve experience for staff as well as patients. So, and that's something that's been very actively pursued and discussed. So I think they was the main points. Please come back if I've forgotten to answer any of them.
Thank you, Kate. And Claire Roche, I'm thinking you might want to comment too on some of the issues that have been raised. Please come in.
Yeah, I think if I could just pick up on some of the points that Kate was raising there. So, first to reiterate, as I put in my presentation, end-of-life care provision will remain both in Bronfleece and Llanidloes sites. And actually, we've done quite a lot of work in the last couple of months to be able to really look at our criteria for end-of-life care. We have been strengthening our standing operating procedure for end-of-life care, and it will be, a key part of the evaluation. And as Kate said, was a real focus for the tabletop exercise that was held last week with a wide range of multi-professional disciplines across different settings, which I think is really important to share. The other thing I think that Kate touched on there was actually challenging ourselves about, have we really got the right care model at the moment for maybe when somebody needs an intervention? Are we always admitting them to hospital when actually we could do something particularly different and we could have more community ambulatory models of care? And for me, that links directly back into Steve's question, which I will come into in more detail now, around actually that provides huge opportunities for a wide range of skills from our nursing colleagues. So I think for me, it offers far more opportunities for us to be able to be very open and very creative to new ways of working that are far more focused to community and enabling people not to go into hospital in the first place.
Thank you. I want to bring in Jen and then Chris, and then we probably will have some more responses from executive colleagues before bringing this section of our discussion to a conclusion and moving on. But Jen, please.
Thank you, Carl. My question is about one of the statements in the paper about improving the rehabilitation culture within, obviously, the proposals for the rehabilitation units, etc. I was really struck by that, and I suppose I just want to understand a little bit more. What's the ambition which is driving that statement? What is it that we're looking to achieve, and how will these proposals drive that improvement in rehabilitation culture? What does that mean, and how do these proposals enable us to drive improvements in that area, and why is that a good thing? I'd be keen to get to the bottom of that, please. Thank you.
Thank you. And Chris.
Thank you, Chair. Thank you, Claire, for the presentation. Some interesting stuff on there. Firstly, I do agree that the loss of independence and confidence of people remaining in hospital is an issue, so we need to address that. In relation, you mentioned about agency spend. I just wondered whether we'd done any modelling of the anticipated savings that can come from these changes regarding that, because I think it does have an impact. Again, what you mentioned about being cared for by the same team rather than different people coming in. One of the aspects that I was looking at is, do you, in relation to the evaluation, in relation to length of stay, are you anticipating a reduction in the length of stay in these ready-to-go units with these changes being anticipated? And also, what has been staff's reaction, bearing in mind what Kathy had indicated previously about the reactions to some of the changes within the minor injury units to these changes that are proposed on these alternative sites?
Thank you very much, Chris. So we probably have a few executive colleagues that might like to comment on this. Can I ask that we be as succinct as possible, because we do have a couple of other sections of our discussion to get through before we conclude our meeting today. But I'm going to go initially to Paul. Thank you, Paul.
Yes, thank you, Chair. Yes, well, I wanted to start by saying that it's been a privilege to sort of oversee the progress of these cases as chair of the Strategic Change Programme Board. And there is an abundance of evidence in relation to deconditioning which supports this case. That's a quote from Abby Hall, a professor in the University of Exeter, in a paper in 2017. And that led to a paper from the British Geriatric Society in 2019, outlining the serious preventable harms that there are in our system that Claire, our nursing director, has elucidated so clearly. And there is no doubt the model that we are adopting sits well within the NICE guidance. That's NICE guidance 74, which is about bed-based community or acute hospital provision whilst people are waiting care packages. So it satisfies those standards, and it also is mentioned in standards in England and Scotland as being vital. In fact, tackling deconditioning is a duty, and we need to undertake this work in order to fulfill that duty. In relation to the length of stay, may I say, we do anticipate a reduction in length of stay. It's very difficult to be certain about actually what the magnitude of that might be. But as we have a high length of stay in Powys initially, there's an opportunity here to significantly reduce that number. And the way that would happen is almost certainly if you can prevent patients from deteriorating whilst on our wards, then they go from it prevents them from being simple discharges they go to complex discharges otherwise. So it makes the discharge process easier, and it also would reduce costs. So in relation to both quality, value and safety, this is the absolutely right time to be doing this piece of work.
Thank you, Paul. Claire Roche.
Thank you, Chair. So I'll try and pick up a few points here in turn. In relation to Chris's point around length of stay, yes, that will be a key thing that we will be measuring, Chris. Obviously, we need to recognise the complexity of the whole system, and you know what has clearly been articulated earlier on in the presentation this afternoon around the complexity of being able to get people home into care homes, etc. But equally, I think this is far broader than that. This is about length of stay across the whole system. When we think about the fact that we're talking about maximising people's independence, preventing deconditioning, being able to prevent readmission, then actually this is about being able to prevent the need for further admissions and therefore be able to address length of stay as a whole system. You asked me in relation to the staff reaction. I think that the staff reaction has been quite mixed, if I am being truthful. We have had some staff that have been concerned about the changes, and equally we have had some staff who have been, dare I say it, both excited and energised by these changes, and probably links in to some of the conversation that Kathy had earlier in that actually staff have been talking about the fact that we need to do things differently for quite a while. I do want to give the board assurance that as the Director of Nursing, I have made myself visible within the areas identified to be the ready-to-go units, both in terms of visiting the wards and enabling staff to have access to me at a later date to be able to discuss those concerns. In relation to the modelling around agency, so yes, we have done some indicative modelling and you will see that in the papers, and that is based on the rostering arrangements. However, of course, we will also be looking through the evaluation in how we can be organising ourselves differently. What is it that we can be doing to maximise even further efficiencies? That's not included specifically in the papers, but it will certainly be part of how we will evaluate and be leading that change within those areas. I do want to come back to Steve's point because I think it is a really, really important point. Steve, you asked me about the nursing staff skills in the ready-to-go unit, and would staff lose their skills? And you also asked me about the proportionality of registered nursing staff and healthcare support workers. This is something I feel really strongly about. I'd really like to remind the board that the key role of a nurse is to promote health and prevent illness. That's very clearly articulated by the World Health Organization. Our own Nursing and Midwifery Council Code of Conduct makes it very clear that our role as nurses is to prioritise people, and in doing so, both deliver the fundamentals of care effectively and act as an advocate for our patients. The Royal College of Nursing is very clear that the role of the nurse is to assess, plan, implement and evaluate high quality person-centred nursing care. And I think all of those things together articulate very clearly the very important role of the registered nurse in the ready-to-go units. Given the very rural nature of our units, I will not, as the Director of Nursing, support a reduction in registered nurse staffing, less than 2 nurses on duty. And this is absolutely consistent with the approach I have taken to establishment reviews across the county. Nevertheless, during this evaluation, of course, I will be looking at the nursing establishment in order to understand if we have those rostering arrangements right for the ready-to-go unit. And finally, in relation to the skills of nurses, it goes back to something that was said earlier. Our focus has to be on how we deliver interventions to patients within community and ambulatory settings, rather than admitting patients to hospital where we could do something differently. And I truly believe as we develop those ambulatory services that actually our nurses will be required to have more skills. And I am also keen to look at any option that will maintain all of our nurses' skills, including rotation. Thank you very much.
Claire. So we go now to Claire Madsen.
Thank you, Chair. I just wanted to pick up Jen's comments around rehabilitation. I think we're looking at rehabilitation in its widest sense of that definition. So if we look at our ready to go wards, this is about empowering patients to remain as independent as possible. So we're recognising that we may need to upskill some of our staff to really embed that rehabilitative model into that unit. So we've got a robust training package that we've put together, which we will put all of our staff through to ensure that everyone has the same skill set on those particular units. And also to answer some of the questions around mitigation that came up earlier, we've been working really closely with our third sector colleagues, and we will be embedding community coordinators onto those wards to ensure that patients are signposted to the most appropriate services and support for their individual needs, so very person-centred care in those areas. And with regard to the rehabilitation units, we know from the evidence base that Paul was mentioning, certainly the evidence, nice guidance around stroke, that if we concentrate highly skilled multidisciplinary rehabilitation staff around patients and work with them in a very concentrated way, we get the best outcomes. We do tend to reduce the length of stay depending on the complexity of the patient, and we can bring back more challenging patients, because if we only have a few staff, we can upskill them and maintain their competencies because they will be using those skills on a daily basis. So it enables us to enhance our rehabilitation offer across both of the units that we're developing. Thank you.
Thank you, Claire. But before I invite the Chief Executive to offer a final comment and observation in this section of our discussion, I just want to pause so that any independent member has the opportunity to come back in if you feel that your question hasn't been answered or you haven't received the assurance that you were seeking. Hayley, would you like to come in, please?
Yeah, thank you. And, you know, all of my colleagues have answered all the questions. I just had a couple of additional points, if that's okay. The first one is looping back to our commitment to ensure that there's no unintended consequences as a result of these changes. In terms of the sustainability of primary care, right at the start back in the July meeting, I indicated very clearly that we need to make sure that we don't destabilise any part of the system as a result of these changes, and clearly the role of our GP colleagues in providing medical cover across all of our sites is absolutely essential, as well as the broader role that they play. I know I've had some queries before about concerns that changes might have an impact on GP recruitment, and again Kate and others have been having discussions about other opportunities to make sure that that is mitigated for this temporary period of the next 6 months whilst we're testing this new way of working. The other issue that I wanted to pick up was around mitigations. And in particular, looping back, Carl, to the start when Katie referenced the 6 points in the letter that Llais returned to us with regard to the letter following the completion of our engagement process. And we've got a track record of working very closely with Llais, in particular through their input as observer status in checking how we're taking forward some of those mitigations. So, for example, Simon's questions around flexible visiting times, how we're mitigating the impact, will be and is part of this process of the next 6 months to monitor against that. But I wondered whether, 2 things I wanted to say. The first thing is the 6 recommendations in Llais's letter, which covers their continued observer status on the arrangements, checking our evaluation, ensuring that there's a commitment to evaluation, and also the question around reversibility and their input in the mitigation and activity and commitment to monitoring the impact across all affected service areas is something that we would be working on the basis of implementing those points over the next 6 months. So I don't know whether Katie would like to, as Regional Director, reference their role in supporting mitigation work, but I think it might be helpful assurance to the board about how we'd work very closely with Llais on those matters. Thanks.
Please come in, Katie, if you'd like to.
Thank you very much, Chair. Thank you, Hayley. Yes, just on Simon's point, really. The mitigation plan is absolutely key for us. And as Hayley says, we've had fairly recent experience of that, where we've reviewed the mitigation plan together, the Health Board and Llais, on a sort of fortnightly basis. And I think the board have had updates against those sort of that work. So we would be very keen. I think that worked very well. From our point of view, it was very good practice. We'd be very keen to look at a similar approach and to work with you looking at a similar approach going forward.
Thank you, Katie. Thank you. So we're going on to the final sections of our discussion today. I'm very conscious that our meeting has already taken more time than we had originally anticipated. And colleagues, I am going to ask for your cooperation. As we know, these are very important matters. Our population, whom we serve, has a keen interest in these matters. And I think it's very important that we give the matters the time they need, rather simply than being controlled by the clock. And therefore, clearly, our meeting will take a little longer than we had anticipated. However, we go now to some thoughts, some comments and input from Hayley on the level of confidence within the organisation in relation to delivering these proposed changes if they are supported. Thank you, Hayley.
Yes, we thought it was very important to cover this point, to give the board confidence that we can deliver if the proposals are agreed. So the first thing to say is that our plan would be, if it's supported, that we would be able to get the changes implemented by the 1st of December. That lead-in time is to support rota changes and other preparation work that we would be doing operationally to be ready. The monitoring and evaluation frameworks, we haven't discussed that a lot so far, but I would really draw the board's attention to how we're planning to monitor and evaluate, and in particular, our plans to regularly report to the board on progress. It's really important from my perspective that we're really clear that we're monitoring this throughout the 6-month period. And clearly, if there are any issues that trigger us to be concerned at any point, some reassurance the board has sought from the start of the reversibility of our ability to change back to the original model. And again, that will be subject to the ability to reset rotas and obviously patient selection choices in the inpatient environment. The key mitigations we've discussed in the integrated impact assessment and how we're planning to monitor those through the Strategic Change Board, but also the important role that Llais, Katie has just shared of the experience with the Gilwern mitigation plan, that would be forming part of this, and also recognising that we feel that it will be important to establish a community hospital governance forum for ongoing GP engagement. We've started the tabletop exercise work and started that work, but we need to put it on a more formal footing as part of this process to make sure that we can give confidence to the board that we've got the right level of engagement throughout the implementation period of this. And then the final point is to give you confidence really that, you know, our assessment as an executive team in terms of implementing this change, we have done some detailed planning, operational planning regarding this, and we are confident to hit the deadline and to have that evaluation approach established from the start. So that's all I wanted to say about that. Just in terms of the point right at the beginning, when we talked about our confidence in relation to meeting the service change guidance, and that we've heard also earlier from the from the public engagement report that there were calls for the process to be stopped and revised, and a number of questions and comments regarding the sufficiency of the engagement process. So the first thing to say is we did revise our approach. We moved to a 6-week period in light of the discussions with Llais, and in the context of assurance of engagement and decision making. the key issue for the board is whether we are satisfied that Welsh Government guidance on service change and associated requirements have been met. Our view as an executive team, we've considered this in detail, both in relation to the individual changes on their own merits and also pending the consideration that we've had of the 6-week period of engagement, that clearly this is really important for our communities because of the scale of response, and there's a clear body of opinion and strength of opinion regarding these changes, but we feel that the changes are relatively small in nature. The 6-week overall period of engagement, with the decision being taken in public at board today, as well as the consideration of the engagement and the mitigation and integrated impact assessment work that we've presented today. And also a really important point that Simon asked me to clarify, the clear commitment that these changes are temporary in nature and will be brought back to the board, and the full evaluation will be brought back to the board. And then the final clear commitment that we will need to do further work to have the right dialogue and engagement to agree the longer term shape of safe and sustainable health services for Powys. So our recommendation is to the board that we should have confidence regarding the adequacy and completeness of the process leading up to the recommendations contained within the papers today. That's all I wanted to cover, Carl. Thank
you, Hayley. Hayley, you mentioned that not much of our discussion, or we've done a lot of discussion today on the evaluation. Really, really important, as you quite rightly say. And I just want to add a comment to yours that, from a board perspective, that link between the effectiveness of the evaluation and the nature of the temporary changes that we're considering today is clearly one that we will keep a very careful eye on. And of course, we have the detail in the papers that we've all read prior to this meeting as regards to the measures, the indicators, the information on which the evaluation will take place. And I would certainly encourage any independent members to ask questions or to please come in if you want additional assurance, or if you have any specific questions about the appropriateness or the effectiveness of the proposed evaluation methodology and process. But certainly, exactly as you say, Hayley, the temporary nature of these changes will be dependent on what that evaluation says to us in 6 months after their implementation, and then any necessary decisions at that point will certainly be taken. Does any colleague want to come in relation to the input from Hayley? So we'll go firstly to Jen.
Yes, thank you. I haven't got a particular question on the monitoring and evaluation process. I do take assurance from that, and as we've said, that the outcomes from that work, both the principles and the outcomes from that work, will be coming through to board. So I feel there's a robust infrastructure around that. My question, Hayley, is around should these proposals be approved? Does the fact that the temporary period of 6 months, which falls over the winter period, where we all know that there is increasing pressure on NH services, can these new proposals, should they go forward, withstand the winter pressures that we know are going to come on our services? Thank you.
Thank you. And Kirsty, please.
Thank you, Carl. Obviously, in the evaluation, there is an emphasis on hearing directly from patients. So I just wonder if we could give some more detail on how we intend to capture patient experience as a result that people might, have as a result of these proposals if they're agreed today.
Thank you. And Nina.
Thank you, Chair. Nina Davis, Associate Member. I just wanted to note and welcome that Social Services will be involved as a partner in terms of the monitoring and evaluation plans. I think that would be really important. So I just wanted to raise that, but also that I think it'd be really important throughout the trial period, particularly with the ready to go homes, that Social Services, but PAVO and third sector are involved throughout that period, wrapping around the wards if the proposal is agreed today. So I just wanted to note that. And then I was going to add a comment as well about the importance of engagement with families and patients, but I think Kirsty covered that just before. So thank you, Chair.
And Katie, please come in.
Thank you, Chair. Just on Kirsty's point, really, if and should you agree to these proposals, we will make sure that all of them are considered in our planning for 24-25 with regard to visits and getting specific patient experience feedback. And I'm sure organisations like PAVO would be committed to doing that as well. So just to give you that assurance, should the decision be taken.
Thank you. I'll ask Hayley to comment. So we've had questions on the extent to which we can implement these proposals and also sustain winter pressures, and particularly from Kirsty around the capturing and of patient voice information and how that will be fed in and influence the evaluation. So firstly to you, Hayley.
Thank you, Carl. On the first point that Jen raised, which is withstanding winter pressures, the first thing I wanted to say is that firstly, there are no changes in bed numbers or number of sites as a result of these proposals. It's the same capacity that we've currently got that will be going into the winter period. And therefore, there's no reduction in capacity. That's the first point. The second point is around this is part of getting ready for winter, because the reality is that we need to address patient flow delays across the whole system currently. We regularly, on a day-to-day basis, have a large number of patients who are delayed, not able to be brought back into the county and not being able to be discharged from our community hospitals. So we are really seeing the evaluation of this model, particularly being around making sure that we can improve productivity and flow and reduce length of stay, and the associated benefit of that for the patients around maintaining independence we've covered earlier. I think the important role of the third sector, particularly our community connectors and our discussions about how we wrap around these services more proactively, and the important joint working with social care is absolutely critical and will form part of the evaluation. And I'm particularly I'm glad Katie mentioned the role that Llais has in also bringing insights from patients and the public about experiences, and I know they've already got planned work to look at, for example, urgent care provision in the next few weeks. So all of that will be drawn together. But I would say is that winter is always potentially unpredictable, Jen, and there will always be times as a board we might have to take alternative decisions operationally to manage system pressures and flow. In the eventuality that there's anything that changes over the next few months that potentially means we have to have another think about this, we will be ensuring that we're communicating that very clearly, both to the board and also to the public. Do I envisage that? No, because the whole purpose around this is to actually improve our productivity and get better outcomes. But clearly, who knows what winter will bring, and it will be very important for us to respond on a very rapid basis if we need to be agile about what we're doing as a system across Powys, but also with other partners to respond to that. If it's okay, Carl, I'd like to bring in Claire to respond on the capturing of patient experience, if that's all right. Thank you.
Thank you, Claire.
Yeah, thank you, Hayley. It's a really, really important question in terms of our focus on patient experience. And we will be doing this in a number of ways. So first and foremost, to say we will be proactively getting feedback from our patients using these services, but also seeking to ensure that we get feedback from family. It is, it's as important that our family of our loved ones as well as our patients have the opportunity to be able to give feedback. We've got a number of ways that we can do that. So we've got existing systems that we can use, but equally we will be open to maximising every opportunity to gain feedback so that there is no barrier to patients and their families being able to provide that feedback. It's also really important to say that we need to triangulate other intelligence. So a really key indicator will be monitoring both our complaints and indeed our compliments that we may have in relation to all of these services. And Katie touched on it just now, working both with Slice and Parvo and other partners, it is absolutely vital that we gather the intelligence that they gain to be able to triangulate it. So I think overall it's about having a multi-pronged approach to be able to gather as much triangulated intelligence that we can, so we have a high degree of confidence that this is meaningful feedback and we are really understanding the experience of our patients. Thank you.
Thank you very much, Claire. I can't see anyone else wanting to come in, and therefore I am going to move to the recommendations before us today. Our usual way of operating as a board is to make decisions on the basis of consensus, and so I see no reason why we should change that approach today. As I've listened to the discussion and as I have heard what people have said, I haven't heard that particularly independent members have challenged the assurance or felt that their questions haven't been answered. And therefore, I think it's right and proper that I should nonetheless, if we base our decision on the basis of consensus, does any board member want to indicate that they wouldn't join that consensus in supporting the composite recommendation in front of us? And just before you do that, I do want to read it out. So it is there on the slide, but given the importance of these decisions, so we are asked to note the changes to decision making and timeframe agreed following the midpoint review with Slice on the 13th of August 24. We are asked to receive and discuss the delivery of the engagement process and the key themes identified from the engagement process, to receive and discuss the correspondence with Slice, to receive and discuss the update on staff engagement, to receive and discuss the update on primary care engagement. We are also asked to take assurance from the assessment of delivery confidence and to note the monitoring and evaluation frameworks and implementation timetable. Also to take assurance from the assessment of the engagement and decision-making process. Critically, we are asked to approve the implementation of temporary changes to minor injury unit services in Brecon and Llandrindod to open from 8 AM to 8 PM for a 6-month period, with evaluation and monitoring in place as set out in the monitoring and evaluation framework. And also to approve the implementation of temporary changes to community hospital model with Llanidloes and Brownlees as ready-to-go-home units, and with a strengthened role for Brecon and Newtown to provide community inpatient rehabilitation for a 6-month period, with evaluation and monitoring in place as set out in the monitoring and evaluation framework. Colleagues, does anyone want to indicate that they don't support those recommendations? No one is indicating, and therefore those recommendations are supported unanimously. And therefore, having taken that decision, I'm going to invite Hayley to come back in before we draw our meeting to a close to offer some observations in relation to what happens next. Thank you, Hayley.
Thank you, Carl. And before I go into next steps, I just wondered, there are a couple of points, if you don't mind, or that I felt it was very important for me to reflect today for the record around a couple of areas of questions, if that's okay. The first one is, I just wanted to note that I appreciate that. Thank you for taking the decisions today to approve the recommended changes, but I also note the strength of opinion from the public that we've also had to consider in taking those decisions today, and in particular the work of the League of Friends, which have funded many developments across all of our sites, including funding for the palliative care suite, is very much noted by the board during this period. And I think in particular, I hope the reassurance that we've covered around the use of the end of life capacity at the sites, as well as the discussion around the admission criteria and GP criteria around that, as well as others, will address many of the points that we received only yesterday. I think the other issue for me, I think we've covered the majority of all of the points generally, but I wanted to bring to the board's attention that during this process, I have personally, as well as many of us in public settings and in discussions, been asked for further assurances regarding the shape and delivery of sites, services across the whole of Powys. And I think it's very important that the work on the long-term model starts at pace now, building on the learning from the temporary changes, but also thinking about how we can learn from this last few weeks of doing this work about how we work with the public, staff and partners to particularly make sure that they're helping us to look at the options for the future to keep health and care sustainable in the county, because this is a shared challenge and we can't do this alone. And there are significant opportunities for us to work together to improve outcomes and to deliver for the population of Powys. I know that we've been building on the work we undertook earlier in the year, engaging on Better Together, a sustainable approach in Powys, and clearly we will be bringing back to the November board meeting an update on the next plans around the work to engage and then finally consult with the public on the longer term changes that we're undertaking. And I felt it was very important just to remind the board of the work that we have committed to do around the long-term model. But fundamentally, in terms of the timescales now, we have a strategic change programme board chaired by Dr. Paul Buss, which continues to have ongoing oversight of the delivery of the implementation moving forward now, and our commitment to ensure that these changes are implemented by the 1st December. The important work about monitoring and evaluation will continue, as well as the discussion that we've just had about making sure that we're taking into account all feedback with regard to this, particularly capturing patient experience and the work on outcomes, and that will come back, as well as then ensuring that we have more formally at the end of the 6-month period evaluation coming back to the board meeting, and then a discussion about next steps. So I wasn't going to cover any more, but I wanted to make sure that some of those key points that were raised yesterday were reflected in the final reflections. Thanks.
Thank you, Hayley. And just before we bring our meeting to a close as well, we mentioned right at the beginning of our meeting that a couple of our colleagues aren't able to be with us today. I think just now I have received an email from Ronnie Alexander, independent member of our board, who in his email says that based on previous discussions at board development days, independent member meetings, and at previous board meetings, I'm content to support the proposals for temporary change based on the substantial evidence with which I have been provided. Now, clearly, Ronnie isn't with us today, therefore not able to be part of this decision-making meeting. However, I simply wanted to share that with you as in order to enhance, if you like, the consensus of the board. So thank you all very, very much for today. Thank you for the way in which everyone has engaged with these very important decisions, yes, in this meeting, but also in the weeks and months that have led up to these meetings, and for the way in which we have given full conscientious consideration to these very, very important matters. And Hayley's final comments about the next steps clearly are very, very important. I'm not aware of any other urgent business that requires our attention today, so that concludes this meeting, and thank you very much, and goodbye.